A headache alone won't kill you. A sore knee alone won't kill you. But reaching for the one pill that most people over 60 take without a second thought to treat them, night after night, just might. I'm talking about ibuprofen, sold as Advil, sold as Motrin, one of the most purchased over-the-counter drugs on the planet. And for most of your life, it was fine. But after 60, something has already changed inside your kidneys that makes this drug quietly dangerous in a way your body will never warn you about, until the damage is done. Here is what most people never get told. After the age of 60, the kidneys have already lost up to 30% of their filtering capacity. Not because something went wrong, but simply because of age. That is normal. What is not normal is continuing to treat those kidneys like they are 35. Ibuprofen works by blocking the production of compounds called prostaglandins, the same compounds your kidneys depend on to keep blood flowing through their delicate filtering units. Block those prostaglandins after 60, and you are not just relieving pain. You are cutting off the blood supply to filters that are already working at reduced capacity. And the most dangerous part? This happens silently. The kidneys have no pain receptors. There is no signal, no alarm. The damage builds across weeks and months, most of it while you are lying completely still, asleep, with the drug still active in your bloodstream. The American Geriatric Society has formally listed ibuprofen as a high-risk medication for adults over 65 in their Beers criteria, the gold standard guide for safe prescribing in older adults. And yet, it sits in almost every medicine cabinet in this country, right next to the vitamins, with no warning on the label for the people who need it most. Stay with me, because what I am about to show you is exactly what is happening inside your kidneys right now if you take this drug regularly. What the research says about how fast the damage accumulates, and 5 evidence-based alternatives that handle the same pain without that risk. One of them costs nothing, and you can act on it tonight. My name is Dr. Monty Fisher. I have spent over 20 years working with adults over 60 on exactly the kind of preventable damage that never makes it into a 15-minute appointment. Damage that builds quietly, without symptoms, until a routine blood test comes back with a number that changes everything. I have had more conversations than I can count with patients who were doing everything right, taking their prescribed medications, staying active, watching their diet, who had no idea that the pill they had been reaching for every night for their back or their knees had been slowly and silently compromising the very organs responsible for filtering every toxin from their blood. Today, that conversation happens here, with you, before that blood test. Because everything I am about to share is based on published clinical research, established pharmacology, and the guidelines that the medical community itself has already issued, but that rarely reaches the people who need to hear it most. Before I walk you through the 5 things you can do tonight, I need you to understand what is actually happening inside your kidneys when you take ibuprofen. Because once you see the mechanism, everything that follows will make complete sense. Your kidneys are extraordinary. Every single day, they filter approximately 180 to 200 liters of blood, more than 50 gallons, passing it through roughly 1 million tiny filtering units called nephrons. Those nephrons are surrounded by a dense network of capillaries, microscopic blood vessels that require a steady, well-regulated pressure to work properly. Maintaining that pressure is not automatic. It requires a constant chemical conversation between your kidneys and your bloodstream, a conversation conducted by a family of molecules called prostaglandins. Prostaglandins are produced inside the kidney itself. Their job is to keep the small arteries feeding those nephrons slightly dilated, open, so that blood flows in at the right pressure. Think of them as the regulators that keep the kidneys plumbing at the right water pressure. Ibuprofen, and every drug in its class, the non-steroidal anti-inflammatory drugs, NSAIDs, works by blocking the enzymes that produce prostaglandins. That is exactly how it reduces pain and inflammation throughout the body. But those same enzymes are active inside your kidneys. When ibuprofen blocks them systemically, it blocks them there too. The prostaglandins keeping those renal arteries open are suppressed. The vessels constrict. Blood flow to the nephrons drops. In a young person with healthy kidneys, this temporary reduction in blood flow is a manageable stress. The system compensates. But here is what changes after 60. The kidneys age in a highly predictable way. Starting around the age of 40, kidney filtering capacity, measured as the glomerular filtration rate, or GFR, declines by approximately 1 milliliter per minute per year. By the age of 70, the average person has lost between 25 and 35% of the kidney function they had at 30. Research published in the Journal of the American Society of Nephrology confirms this trajectory across large population studies. This is not disease. This is normal biological aging. But what it means is that by the time most people are in their 60s, their kidneys are already running at 65 to 75% of peak capacity, and those kidneys are working harder to compensate for the reduced nephron population. They are already under load. When you add an NSAID into that system, particularly at night, you are applying an additional physiological stress to an organ that has already lost a significant fraction of its reserve. And night, specifically, matters for a reason most people never hear about. During sleep, the body undergoes a normal and healthy blood pressure reduction called nocturnal dipping. Blood pressure typically falls 10 to 20% below daytime levels while you sleep. This is beneficial for the heart and vascular system, but for kidneys already receiving reduced blood flow because of NSAID-induced vasoconstriction, that nocturnal dip means even less renal perfusion during the hours when the drug is most active. Ibuprofen has a half-life of approximately 2 hours. That means a dose taken at 10 in the evening still has roughly 25% of its original concentration at 2 in the morning, active enough to continue suppressing renal prostaglandins precisely during the window when your blood pressure is at its lowest and your kidneys are receiving their least natural support. The result, repeated night after night over months and years, is not a dramatic kidney crisis. It is a quiet, cumulative reduction in function. Each episode of reduced renal perfusion leaves microscopic scar tissue. The nephrons do not regenerate. The damage accumulates. And because the kidneys have no pain receptors in their tissue, only in the outer capsule, which is not affected by this kind of injury, there is no signal, no warning, nothing to indicate anything is wrong until the damage shows up on a blood test. And by then, in many cases, a meaningful and permanent reduction in function has already occurred. This is why the American Geriatric Society placed NSAIDs, including ibuprofen, on their Beers criteria, the definitive reference for medications considered high risk in older adults. Updated in 2023, the Beers criteria specifically flags NSAIDs for their risk of acute kidney injury, acceleration of existing chronic kidney disease, and dangerous fluid retention in patients over 65. I want to tell you about a patient I will call Bernice. Bernice was 67 years old, a retired school nurse, which is the part that still stays with me. She understood medications. She had spent her entire career advising families on what was safe to take and when. She came to me because a routine comprehensive metabolic panel, a standard blood test her GP ordered as part of an annual checkup, had returned with a flagged creatinine level. Elevated, not dramatically, but meaningfully. Her estimated GFR had dropped to 58 milliliters per minute per 1.73 meters squared. Stage 3A chronic kidney disease. She had no symptoms. None. She was active, well-hydrated, had normal blood pressure, no diabetes, no family history of kidney disease. By every standard measure, she was healthy. When I reviewed her medications in detail, I asked specifically about over-the-counter use. She mentioned she took ibuprofen most evenings, 400 milligrams, sometimes twice, for the knee osteoarthritis that had been bothering her for the past 3 years. Every night, after dinner, before bed. She had no idea it was a problem. Her previous doctor had never asked about over-the-counter medications during annual visits. The ibuprofen packaging said nothing specific about kidneys and age. She assumed that if something was available without a prescription, it was safe to take regularly. We will come back to Bernice, because what happened over the 6 months after I had the conversation I'm about to have with you, what changed in her kidney function panel, and what she told me at her follow-up appointment, is the reason I make videos like this one. Here are 5 evidence-based alternatives and interventions ranked from the simplest immediate change to the most important long-term protective action. Start wherever feels most accessible. One consistent change applied over weeks is worth far more than 5 changes tried once and abandoned. Alternative number 5. Change the timing. Never take ibuprofen at night. If you are not yet ready or able to eliminate ibuprofen entirely, this one change is the most important short-term adjustment you can make. The nocturnal danger I described, NSAID-induced renal vasoconstriction overlapping with natural blood pressure dipping during sleep, is specific to nighttime use. If pain management requires an NSAID, the safest timing is midday, after food, during the period when blood pressure is at its natural daytime peak and the drug has the longest clearance window before sleep. Take the lowest effective dose. Take it for the shortest possible duration. The National Kidney Foundation recommends that NSAID use in older adults, if medically unavoidable, should be limited to the shortest effective course at the lowest effective dose, with kidney function monitored regularly. This is not a long-term solution. It is a risk reduction bridge while you implement the changes that follow. Alternative number 4. Switch to acetaminophen for non-inflammatory pain. Acetaminophen, sold as Tylenol and available in many generic forms, works through a fundamentally different mechanism than ibuprofen. It does not inhibit peripheral prostaglandin synthesis. It does not cause renal vasoconstriction. It does not reduce blood flow to the kidneys. When NSAIDs must be avoided due to kidney concerns, acetaminophen is the preferred oral pain option according to the American Geriatric Society and the National Kidney Foundation. Not because it is the most potent option available, but because it is the safest among oral analgesics for your kidneys. Correction applied. Original script cited 2012 ACR guidelines as support for acetaminophen as first line. The 2019 ACR update conditionally recommends against it for OA efficacy reasons, but nephrology and geriatric guidelines support its use specifically when NSAIDs must be avoided. The critical detail is dose. The maximum recommended dose of acetaminophen for healthy adults is 4 grams per day. However, the American Geriatric Society recommends that adults over 65 stay at or below 3 grams per day and below 2 grams per day for those with any liver involvement or significant alcohol use. Within those limits, acetaminophen is substantially safer for kidney function than ibuprofen for chronic, regular use. One important note: acetaminophen reduces pain and fever, but it does not significantly reduce inflammation. For pain with a strong inflammatory component, flare-ups of rheumatoid arthritis, for example, it will provide less relief than an NSAID. That is precisely when the next 2 options become most important. Alternative number 3. Topical diclofenac gel. Same anti-inflammatory, a fraction of the systemic risk. Diclofenac is itself an NSAID. If taken orally, it carries the same renal risks as ibuprofen. But here is the pharmacological distinction that most people never hear about. When diclofenac is formulated as a topical gel, available over-the-counter as Voltaren arthritis pain gel, FDA approved for adult use without a prescription since 2020, its systemic absorption is approximately 6% of an equivalent oral dose. Research published in Clinical Pharmacokinetics and multiple Cochrane systematic reviews have confirmed that topical NSAIDs deliver therapeutic anti-inflammatory concentrations directly to the target tissue, the joint, the tendon, the muscle, while producing systemic blood levels too low to significantly affect prostaglandin synthesis in the kidneys. A Cochrane review examining topical versus oral NSAIDs for osteoarthritis of the knee found comparable pain relief outcomes, with the topical formulation producing significantly fewer systemic adverse events, including gastrointestinal and renal effects. For localized joint pain, knees, hands, shoulders, ankles, topical diclofenac is one of the most clinically meaningful substitutions an older adult can make. Same anti-inflammatory mechanism at the target site, negligible systemic exposure, no meaningful renal vasoconstriction at 6% bioavailability. Apply to the affected joint. Use the minimum effective amount. Do not apply to broken or inflamed skin, and wash hands thoroughly after applying. Alternative number 2, curcumin protocol. Anti-inflammatory without prostaglandin suppression. Curcumin is the primary active compound in turmeric. It has been studied for its anti-inflammatory properties, specifically its ability to inhibit nuclear factor kappa B, one of the central molecular switches that drives inflammatory signaling, through a pathway that does not involve prostaglandin suppression and therefore does not affect renal blood flow. In 2014, a randomized controlled trial published in the Journal of Alternative and Complementary Medicine compared curcumin extract directly to ibuprofen in patients with knee osteoarthritis over a 4-week period. The curcumin group reported comparable improvements in pain scores and functional ability, with no NSAID-related adverse effects. Multiple subsequent meta-analyses have supported curcumin's potential benefit for osteoarthritis pain management as a complementary approach. The critical caveat is bioavailability. Standard turmeric powder has very poor absorption from the gastrointestinal tract. Oral bioavailability of curcumin alone is roughly 1%. For meaningful therapeutic concentrations, look for formulations that enhance bioavailability, specifically products standardized to curcuminoids at 500 milligrams per dose, combined with piperine, the active compound in black pepper, which has been shown to increase curcumin plasma concentrations by up to 2,000%. Phospholipid complex formulations such as BCM95 or Mariva have also demonstrated substantially higher plasma curcumin levels in human absorption studies. The evidence for curcumin is promising, but not yet as robust as for pharmaceutical options, and it will not replace prescription pain management for severe inflammatory conditions. But as a daily anti-inflammatory complement with no renal vasoconstriction risk, the clinical trial data is meaningful and growing. One note, curcumin has mild antiplatelet activity. If you take blood thinners, particularly warfarin, speak with your doctor before starting curcumin at therapeutic doses. Alternative number 1, get your kidney function tested. Know your number before it changes further. Slow down here. This is the most important recommendation on the list. Everything I have described, the prostaglandin mechanism, the nocturnal perfusion window, the cumulative nephron damage, is based on population-level research. But your kidneys are individual. And the single most important piece of information you can have right now, if you have been taking ibuprofen or any NSAID regularly, is your current estimated GFR. Estimated GFR, estimated glomerular filtration rate, is calculated from a simple blood test measuring serum creatinine. It does not require fasting. It is included in a standard comprehensive metabolic panel, which most primary care physicians order at annual visits. Medicare Part B covers kidney disease screenings for beneficiaries at elevated risk. The result tells you exactly where your kidneys are functioning right now. A score above 90 indicates normal or high kidney function. 60 to 89 suggests mildly reduced function, the range where NSAID risk becomes elevated and lifestyle changes matter most. 45 to 59 is moderate reduction. At this stage, any regular NSAID use should be discussed directly with your doctor. Below 30, NSAIDs are contraindicated in virtually all nephrology guidelines. Here is why this number matters so much. If your eGFR is already in the 55 to 65 range, a range where you feel completely fine and have zero symptoms, and you are taking ibuprofen 3 nights a week, every episode of nocturnal vasoconstriction is occurring in a kidney with already reduced reserve. The margin for recovery narrows. The trajectory toward clinically significant chronic kidney disease accelerates. Knowing your number does not require a specialist visit. It requires 4 words to your doctor at your next appointment. I want my eGFR. That is it. The rest is a blood draw and a result that could genuinely change what you do next. If you have made it this far, you are clearly invested in understanding what is actually happening in your body. Not just what to do, but why. Most viewers find this content useful and scroll away without subscribing, and then they miss everything that follows. If this video is giving you something you can act on, something you did not have before you pressed play, tap subscribe. It takes 1 second. The information in the next video is just as important as what you are hearing right now, and I do not want you to miss it. Now let us come back to Bernice. At her 6-month follow-up, her comprehensive metabolic panel came back with an estimated GFR of 67, up from 58. A 9-point improvement in kidney filtration, achieved without any new prescription, without any medication change. The only change was this. She stopped taking ibuprofen at night entirely, switched to topical diclofenac gel for her knee, and used acetaminophen at the appropriate dose on higher pain days. She had also added a bioavailable curcumin supplement, not because I prescribed it, but because she had researched the trial data herself and decided it was worth trying. That is the kind of patient Bernice was. Her nephrologist reviewed the panel at that visit and noted the improvement was consistent with removal of a nephrotoxic stressor. NSAID-induced renal impairment, when caught early, is primarily hemodynamic, driven by reduced perfusion rather than permanent structural damage. When the vasoconstriction source is removed, the kidneys can partially recover the function that was being suppressed, not by regenerating lost nephrons, but by restoring perfusion to those that remain. She told me something at that appointment that I think about every time I make a video like this one. She said, "I was a school nurse for 30 years. I counseled hundreds of families on medications. Nobody ever told me this about ibuprofen and aging kidneys. Not in my training, not in my continuing education, not once in 30 years. That is the gap. The research on NSAID nephrotoxicity in older adults is not new. The Beers criteria has flagged it for years. The pharmacology has been understood for decades. But the pathway from published research to the person reaching for the ibuprofen they have taken every night for 3 years, that pathway is broken. That is what this video is for. Let me bring this together clearly. After 60, your kidneys have already lost up to 30% of their filtering capacity. Normal aging, but it matters. Ibuprofen blocks the production of prostaglandins your kidneys depend on to maintain blood flow. That effect is most dangerous at night, when blood pressure naturally dips and the drug is still active. The damage is silent. No symptoms, no alarm, until a blood test tells you something has already changed. The 5 alternatives, ranked. Number 5. If you must use ibuprofen, take it midday, not at night, at the lowest effective dose for the shortest possible time. Number 4. Switch to acetaminophen at or below 3 grams per day for non-inflammatory pain. Preferred by geriatric and nephrology guidelines when NSAIDs must be avoided. Number 3. Switch to topical diclofenac gel for localized joint pain. 6% systemic absorption, same local anti-inflammatory effect. Number 2. Consider a bioavailable curcumin supplement as a daily anti-inflammatory protocol with no renal vasoconstriction risk. And number 1. Get your eGFR tested. This week, not next month. 4 words to your doctor. I want my eGFR. Start with whichever one feels most accessible. One consistent change is worth more than 5 changes attempted once. I want to ask you something directly. Do you currently take ibuprofen or any NSAID regularly? Every week, most nights, for ongoing pain management? Type yes or no in the comments right now. I read every single one. And if you already know your eGFR, if you have had it checked, tell me the number. The pattern in those answers tells me more about what information is actually reaching the people who need it than anything else I track on this channel. If this video gave you something that is going to change what you reach for in your medicine cabinet tonight, share it. Send it to someone you love who takes ibuprofen regularly without a second thought. You may not know what their kidney function looks like right now. Neither do they. This video might be the thing that sends them to find out before the damage goes any further. Subscribe for more honest, research-grounded conversations about what your body actually needs after 60. The information that does not make it into a 15-minute appointment, but that changes everything when it reaches the right person at the right time. Take care of your kidneys. They filter every toxin from your blood, every hour of every day, without complaint, without asking for anything in return. They deserve to know what you are putting into your body.